Yes, we are live.
Yeah, like. Okay. So warm welcome to all our Physio TV viewers. Today we are just in the second episode of our Physio TV Physio Grand Rounds, as they call it. And this has been a new show or a new series which has been started in collaboration with Anil Bhave sir. And we are kind of just in the second episode of it. And it's been a very exciting time because in this grand rounds, we'll be actually dealing with real life cases which Sir has treated in the past or in the recent past. And we'll be walking you through the entire steps of assessment, uh, clinical reasoning and management with the live photographs, all right, maintaining, of course, the anonymity of the patient and showing you all some pre and post about what really worked and what did not work. So it's an exciting new series which kind of has much more to do with real life situations. And I think it's the call of the hour for most of the physiotherapists out there who feel that they need more practical solutions in treating their patients. So today we start with yet another round of the Physio Grand Rounds. I have the privilege and honor of introducing Bhave sir so many times during many of his talks with Physio TV. I'm kind of getting familiar with his CV right now because it really goes into lens, and to kind of give a concise introduction to him is not really doing justice, but because of time constraint, we really need to do that. So it has a curriculum vitae that runs into pages and could easily be a chapter in a book. He is a clinical director of orthopedic rehabilitation and the director of Wasserman Gate Laboratory at the Rubin Institute of Advanced Orthopedics at Sinai Hospital in Baltimore, USA, Maryland, that is. He has been instrumental in establishing the Gate Lab at Sinai Hospital, as well as developing rehab protocols for various musculoskeletal conditions, including prehab and post-op management that have now become the standard of care in various institutions nationally as well as internationally. He has many certifications to his credit, including the blood flow restriction therapy, ASTEM therapy, dry needling, and many more. He has been the recipient of several awards, including the very prestigious Jacqueline Perry Award, IAP Oration Award, as well as 4 times Champion of Care at the Sinai Hospital itself. He has quite a few patents, with some of them pending, of developing a lot of braces and apps, including the Guardian Sports Extension Brace, the CKD device for contractures of joints, the Triage app for THR and TKR patients, and co-author of the very famous Multiplier app, which is used for calculating limb lengths in children with limb length discrepancies. He's also a consultant with therapeutic modality companies, including Stryker and Medica. He's on the editorial board of many peer-reviewed journals, including Physical Therapy, Journal of Orthopedic Research, Clinical Biomechanics, just to name a few. So has numerous grant projects. He has worked on, numerous grant projects and has 76 publications in peer-reviewed journals. So has authored many chapters in textbooks of rehabilitation as well as orthopedics, and is a faculty at the annual Baltimore Limb Deformity course and the annual Hip and Knee course, and a faculty at the School of Physical Therapy at Maryland and Virginia. He has been a course chairman at 15 courses and given 341 lectures nationally as well as internationally in about 9 countries. Sir, over to you.
Thank you so much. Let me share my screen. Can everybody see my slide? First slide?
Yes, sir.
Yes, sir.
Okay. So today I want to make it interactive for the benefit of students. I will just show one case that is a long-term follow-up of mine, a very interesting case, but we can talk about what do we need to do to get the patient more functional in the shortest period of time and the best fashion. So I will pose questions. Feel free to, any of you, answer them. Even if you make silly mistakes, that's okay. This is the learning experience. We all learn through making mistakes, or at least in meetings, you can make mistakes. Just don't make those same mistakes on patients. That's the important criteria here. So without any further discussion on theory of total knee replacement or why it is done, you all should know by now why total knee replacement is done, what's the recommendation, what's the right patient, when it should be done in terms of X-ray appearance as well as symptomatic appearance of pain, night pain, intractable pain, Kellegren-Lawrence score of 384 for OA, as well as it's used in rheumatoid arthritis to great success. So it's very commonly done. There are about 1 million new total knee replacements done in North America. And the numbers in India are also rising very rapidly, and you will see them as a patient in your clinic if you are an orthopedic physical therapist all the time. Currently, in our patient population, out of every 10 patients we see, at least 2 or 3 are knee problems, and most of them are total knees or ACL reconstructions in the surgical population. My slides are not advancing. I don't know why. Okay. So I have this first slide. And you will say, what does this have to do with a total knee replacement? So this is my patient who I have worked through the journey of having a right high tibial osteotomy in 1994. Many of you probably were not born in 1994, or some of you were born, I don't know. But this is a patient who we first saw in 94 after high tibial osteotomy. And then in 2009, she had her first right total knee replacement, and subsequent to that, a left total knee replacement. And she continued to do this thing called aerial ballet. This is actually a real bridge in Washington, D.C., and they performed under the bridge. I visited this to see it live, and she is right here. This is her, and this is her colleague performing what is called aerial ballet. And I'm going to move the camera down here so everybody can see this picture. This is a similar picture, same routine done in aerial ballet. So the question is this possible? Does the technology allow motion? And is it the technology that allows motion, or is it the patient and the therapist that makes it better? So remember that this patient had multiple surgeries. And the interesting thing is she herself is a physical therapist, but went through significant problems during her rehab, especially on the right side. So if you look at all of her range of motions, she has superb range of motion. You can see her full extension. You can see her 150 degrees of knee flexion with squatting. She can pretty functional in terms of her mobility. And you can see the scars here for a total knee replacement bilaterally. And then you can see the old high tibial osteotomy scar laterally on her right side. So what was her journey in 2010, I think, for the total knee replacement? She developed a flexion contracture. She developed a flexion deficit. She had a terrible time getting range of motion. Why? Because she was preoperatively stiffer after high tibial osteotomy. Once you have one surgery, you are a higher risk patient than a standard total knee replacement that has full mobility. So we had to work our magic, and we are not going to go into details today. We are going to do a follow-up on technology and techniques, but we had to do our magic in terms of splinting. We use dynamic splinting. Hopefully we have time to show you that. And then we had to work on deep tissue mobilization and the standard therapies. Controlling swelling was an important part of our early rehabilitation. Doing more active and active assisted range of motion without causing inflammation, this inflammatory response was critical. She being a therapist, home exercise program was not a problem, or a splint wear was not an issue. And then getting her range, and then followed that with strength that supplements her range. And we tend to always, one of the things that I want you to take home today, also remembering about patients, is we always do progressive resistive exercise. And if you remember what is a Blick's curve, okay? Remember Blick's curve, we are always strong in the mid-range of motion. So patients tend to use the mid-range for moving weights. We have to reinforce the strength improvement in the end range, the last 15 degrees of extension and the last 25 degrees of flexion. If you are strong during that range of motion, then you can function with extreme competence in terms of activities that are not just functional, but they are more related to higher grade activities and sports, and which is her need was. And a lot of the coaching for her was talking to her, guiding her. Not every patient is like that, but in her case, it was like that. And eventually, she returned back to the aerial ballet as well as a very active physical therapist. Now, what's so special about this case also is that since then, I have had a 1-year follow-up with this patient for last 24 years. So these pictures were taken recently at Sinai Hospital by me. So this is not pictures of 2010, 2012, 2014. These are pictures of 2022, January. So long-term follow-up. Now the question always comes, oh, this is a better prosthesis. This gives better range of motion. Oh, this is a new generation. This is a new technique of doing it. This was a standard technique. This was a standard total knee replacement as invented in 2010. And this is the result in 2022. So my point here is that long-term results are obtained not just by prosthetic design, surgical technique, but also are obtained by careful therapy and a great patient, or a compliant patient. Our job is not just we are not mechanical engineers. We have to treat a patient, meaning we have to treat both the body and the mind. And it's important to motivate our patients to do well. And this is particularly true for more elderly. This lady was 55 when she had the first knee done, because she had a previous injury. That's why she needed a high tibial osteotomy. And then she had the second one done when she was 57, and she's now almost 70. So the point I'm trying to make here is that we have to encourage our patients to do better. It's not always the design of the prosthesis or a different technique of doing surgery. It can be very simply a carefully followed protocol with long-term follow-up can teach you a lot more as a therapist. Now, you have to also grant that you have to have great surgery to have a great outcome, no question. Because if you have bad implant design or a bad alignment, you're not going to do well. But given that this surgery now has been perfected by thousands of surgeons, and most surgeons can give predictable kinematic alignment of the joint, the question then becomes is why some patients don't do as well as others. And we have to look at that and what I call risk stratification. How are we stratifying the risk? So for example, how many times do you check when you treat a patient with total knee if they are on thromboprotective medicines. So I open this for discussion. What is the standard use of thromboprotective mechanism in your hospitals? And anybody can pick up this. What I mean is, for DVT prophylaxis, what do you use? Does anybody know?
So usually we use Flexion in early post-operative days.
Early meaning, define early. How long?
I'm not so sure, sir, but approximately 2-3 days, or it depends, varies depending on the patient's situation.
Are the patients placed on DVT prophylaxis for longer period of time? And what are those? Which patients are placed on that?
Patients,
so there is a risk profile for patients where they need to be placed on DVT prophylaxis. The only point I want to make here is that your therapy should be based on what type of aggressive DVT prophylaxis you're doing. Why do I say this? Is that undue stresses placed on the joint through passive range of motion or extreme range of motion early post-op actually can cause more damage than good, because you can cause hemarthrosis. The hemarthrosis, becoming a scar tissue or a solid substance from a bleeding in the joint, only takes 4 days. So you don't pick up in 4 days that they have hemarthrosis, they will never have good range of motion. So it's very critical to know whether they are on long-term warfarin, oral, or they have been placed on Coumadin. Are they using stockings? Are they on aspirin? Because some of the DVT prophylactic agents can cause bleeding in the joint, correct?
Yes, sir.
Okay. So it's important to know that and then treat the patient accordingly. You don't want to cause swelling, both intra-articular effusion or bleeding, as well as tissue response in extra-articular tissues like extensor mechanism especially. You don't want to cause that, because then the response is poor. So emphasis early on active and active assisted range of motion and not doing passive manipulation is very important. Positioning is more important. Quad sets are critical. Patient-guided or patient-directed therapy early on is important, because you can avoid a lot of these problems by doing some things that are important. Next topic for that is, when do you allow stair climbing in your patient in reciprocating gait? When should the patient do up and down the stairs?
Anyone can answer.
Anyone can answer. And this is, again, you can make mistakes here. Don't make the same mistake on a patient, that's all. So what we have learned over time, and if nobody wants to answer, I will answer, is physical therapy and activity is not tablet 3 times a week. You take it passively. You have to judge the patient's response. I have held patients from doing reciprocating steps up to 3-4 weeks, because I believe that the stresses that are caused on the extensor mechanism when you are going up the step that causes inflammatory response or swelling are far more detrimental than not doing the steps for a few days, or do one step at a time, good leg up, bad leg follows, and coming down, the good leg down, bad leg down, good leg follows. Especially coming down the steps, there is so much eccentric load on the quadriceps as you come down, with the trailing leg being the total knee. It is the worst thing that you can do to the patient. So if there is no swelling, there is no response, so we try 4-inch, 6-inch step. Does everybody know what is the step height? You should all know this. Have you ever measured the height of the step, the standard height of the step ever?
Sir, approximately 6 inches.
It's 7¼ inches. And it's a big difference because we have done some gait studies, which then we'll tell you in a second how much difference 1 inch makes for knee flexion, range of motion, especially with the total knee leg trailing down. 7¼ inches is a standard step height across at least North America. You should check your step height. And certain apartment buildings have a higher step height because they have higher ceilings, and certain don't. And it's very important to know what it is and how much flexion the patient is doing and how much load they are putting through the knee, especially early on, not to inflame the joint. I had to actually limit this patient's activity early on because she was responding. She was she believed as a PT that she could do stairs quickly and regain her quad strength. But actually, sometimes it can be detrimental. So my point is always be guided by the response of the patient to your routine or therapy. And everybody should spend at least 3 to 5 minutes assessing the patient the first time they show up, but also every time they come to the clinic. We should spend some time in assessing, asking the patient the right question so that we understand what they are going through. So just to show you, these were her scars. You can see a lateral long scar done in 94. This is 2010. And this side is 2012 or 13. And we have a very good policy in our clinic. We offer our patients every year a follow-up just to come and chat, just to discuss and see if they have any issues, any problems that we need to see. I treat a lot of Indian women, not just Indian, but Asian women, and they all want to sit on the floor, everybody. And when should we allow that? Is a question. That's the next question for the group here. When can we allow cross-leg sitting for long periods of time?
Sir, so ideally here we don't ask them to go into cross-legged sitting or even use the standard Western commode facility. We ask them to use a commode chair or something of that sort.
Correct, early on. So the question was, when can you allow cross-leg sitting? Never?
So actually, here many patients are told not to sit cross-legged ever after
Why?
their knee replacement.
Why? Do you know why? Have you asked the question?
Yes, sir, we have asked actually, but they say that it's surgeon's call. So some surgeon allow it and some don't allow. So depending on that fixation, it will vary.
Correct, but what do you mean by surgeon call? That's not science. That's opinion. It's not a fact. What's the science?
I don't know, sir.
Okay, well, you should.
Sir, so maybe
So when the person says that they want to sit in cross-leg sitting position, they usually mean that they want to sit on the floor in cross-leg sitting.
Yeah.
So that also accounts for eccentric control of quadriceps, which again we can decide on the basis of response that the person gives and the assessment. But if the person wants to sit cross-legged on the bed, which does not account for the eccentric control of quads, we can ask them to do it as we get the range at the knee and the range at the hip.
And the control.
And the controls.
Good. Very good answer. It has nothing to do with with opinions. It has something to do with science, physiology, which is, does the patient have stability in the joint? Number one, to do it. Number two, does the patient have control to do it? Number three, can this patient safely get down on the floor without hurting themselves? So we not only do it on the bed, we also use it on the mat, low mats. And the third thing is, does the patient have muscular control to do it, right?
Yes.
Just
Yes,
remember
sir.
one thing, dynamic stability of the knee joint is all about joint architecture, the slope of the tibia, and muscle control. That is why in the world today, more than 50% ACLs are now recommended not to get repaired. They get rehabbed. The ACL doesn't regenerate again. It's just the rehab takes over, brace takes over. So dynamic control of the knee joint is about muscle control, stability, eccentric control, coordination, and safety, right?
Yes, sir.
Okay, all right. How many people are allowed to squat, or can they?
Yes, sir, they can. Initially, they can start with the wall supported squats and then go deeper with the mini squat and then the independent squat with.
Very good. Very good answer. What would you do simply in clinic that would help them get the eccentric control, that you don't have to have special instruments or anything like that? If I'm a patient who is rehabbing and I want to gain eccentric control of the quadriceps without causing too much harm to my leg, what would you do?
Sir, sit to stand just by using the chair.
Sit to stand is a concentric activity, right?
Like sitting down would require some
So,
eccentric of the quads.
correct. So sitting down, also shallow squats against the wall, going down is eccentric, right?
Yes.
What else? What else can you
Descending
recommend?
stairs.
Huh?
Later we have stages. Descending stairs.
Before you do the stairs, because that can put stress, what would you do? Very simple thing. Step down. 4 inch, 6 inch, 8 inch.
Yes.
Right?
Right, sir.
And then you can add a TheraBand to the back of the leg and control it and actually add more resistance. Right?
Yes, sir.
Yes, sir.
Yes, sir.
You can also do closed chain. In my rehab, I never use weights. I don't use machines. I use straps, bands, and hands. And then after maybe 2 months or 3 months, I use Biodex for testing and rehab further. In the first almost 6-8 weeks, I never use any machines, ever. I use, as you can see, I use these yoga belts that are on Amazon for like $10. We even have the patients buy them. Just the picture in between is a standard exercise that we use for everybody. Gastroc stretch, a hamstring stretch, active quad knee extension at the same time. All 3 exercises in one. Why do I focus so much on gastroc length? What do you think? Why am I crazy that I'm trying to stretch gastroc? Is there a rationale for that, students? Anybody wants to take that?
Yes,
No?
yes, sir. There is a rationale for that.
Okay, what is the rationale?
So it translates the tibia posteriorly and it avoids flexion contracture at knee.
Why does it avoid flexion contracture at knee? Because it reduces translation, or it is also a flexor of the knee joint. So the right answer is, in many patients, many patients, I do a test called popliteal angle at 45 degrees of hip flexion. We are used to doing popliteal angle at 90 degrees of hip flexion, which is, if you have a zero popliteal angle at 90 degrees of flexion, you can be a great sprinter or hurdler, but it translates nothing in normal life, because most of our activities happen at 45 to 60 degrees of hip flexion. And if you can achieve full extension at the knee with 45 to 60 degrees of hip flexion, you do not have a functional hamstring tightness. If you can extend your knee fully, but you are limited in dorsiflexion, you have a functional gastrocnemius problem. Now imagine that this patient, think of it like this, think of closed chain activity, okay? So now think of this is a very important thing to remember. If you do a dorsiflexion with your knee fully extended, which is what you need for initial stance and through the late stance, but you need 15 degrees of dorsiflexion in normal gait. But if your ankle cannot come up beyond 0, what do you think is going to happen to the knee? Think of closed chain.
It will flex.
Correct. So they will have a functional knee flexion posture, and they will have a flexion contracture. Almost 90% of the times in knee problems, it's not the hamstrings, but it is the posterior capsule, lack of patellar mobility, and the gastrocnemius length that causes loss of knee extension. You can write this down. This is 30 years of treating patients, I'm telling you. And there's a test for that. You just have to test to see if they have adequate dorsiflexion for gait. If they don't have full extension, that's a separate story in supine. Okay, that's a posterior capsular. It could be hamstring then. But if they can extend fully, but they cannot dorsiflex, they are going to walk with flexion contracture or a flexion posture, period. So we have to always remember to stretch their gastroc quick enough, make sure it's not tight preoperatively, and have them use an inclined board to stretch with body weight to stretch the gastrocnemius. It's a critical measure of getting functional knee extension during gait and activities. That is one of the most important things to remember in knee rehab. It has nothing to do with the knee, but it's the most important muscle. It's also a very important muscle during push-off phase. And many older patients are weak and they have poor push-off, and their gait is, we'll talk about that separately of maybe another topic we can discuss is just gait mechanics some other time. But just do a test. And the easiest test that I find is the flex the knee first in patient in supine, maximally dorsiflex the ankle, and then slowly straighten the knee. And you will start feeling the pressure build in your hand as the forefoot starts to go down if the gastrocnemius is tight, since it's a two joint muscle, right? Everybody understand this?
Yes,
Yes.
sir.
Yes. Yes, sir.
You'll start feeling the pressure. When you start feeling the pressure, you know it's the gastrocnemius, because remember, patient has to get dorsiflexion somewhere. And if they don't get it in the ankle, they're going to flex the knee. We have done gait studies on this, looking at the effect of, we have used very advanced muscle mapping and muscle length techniques called SIMM. We have looked at this carefully in terms of the effect of gastrocnemius on knee flexion versus hamstrings, and which muscle in hamstrings is more commonly seen as a problem in especially osteoarthritis or total knee patients. And most of the times it is either short head of biceps, lateral gastrocnemius are the main culprits in terms of muscle length, posterior capsule, and the last one, the most important, patellar mobility. Lack of knee extension can be caused by lack of superior mobility of the patella, or what we call patella baja. Everybody know that term?
Yes, sir.
Patella baja, patella alta. And
Yes,
the commonest cause that I have seen in patients is previous injury to the extensor mechanism with shortened patellar tendons. Those patients are likely to go into more knee flexion. And if you don't restore their patellar mobility, their active extension is always a problem, and then results in a flexed knee posture. So improving the superior mobility of the patella during extension exercise and inferior mobility of the patella during flexion exercises are very, very critical. Everybody know what's the total excursion of patella over knee joint in full flexion to extension?
7 centimeters. 7 centimeters.
7 centimeters.
6 to 7 centimeters is total, depending on height of the patient. Of course, if you're a 6 foot 7 inches basketball player, then it's going to be more. And the interesting thing is, in the first 45 degrees, there's not a much of range of motion of the patella, meaning the patella doesn't have to. The soft tissue slack actually will do the job. So when patients have restricted mobility of their knee joint, or they don't move because of pain, posture, whatever, then the patella kind of gets stuck down. And the inflammatory process around the knee joint leads to the fibrosis of the quadriceps tendon, patellar tendon, the fat pad around it, and the retinaculum. And thus, eventually, it becomes a captured patella syndrome, which is the patient is flexed about 15 degrees. The patella is not going up or going down. So early patellar mobility, superior and inferior, is critical in all knee rehab. Doesn't matter what the patient had. Even for osteoarthritis rehab, if you can get active extension, then the load on the knee joint is less. ACL rehab, if you do a patella bone, early restoration of patellar mobility, not just passively, but then supplemented that with this exercise that I'm showing you in the middle here, which I call active assisted quad set, to full extension, and in ACL patients to even few degrees of hyperextension, is very critical in getting that active extension and that patellar mobility to achieve extension. And same thing goes for flexion. So if you are doing a flexion exercise, and I have a method that I use for measuring that in terms of, you mark the superior pole of the patella, and next time I will just show the slide, and then you bend the knee and see where the superior pole of the patella is. That gives you an idea as to how much the patella is moving. And you should all try that on your own legs to see how much, at what degree. Measure at when you measure it in full extension, then mark it. measure in 60 degrees of flexion, 100 degrees of flexion, and then at 125 or 130, whatever you got. And that will give you an idea how the patellar mobility is affecting. Also, try to lock your patella or have other colleague hold the patella up superiorly and try to bend the knee. Or hold the patella down, flex the knee and try to extend the knee. Both are harder. And that's the key. The key to knee rehab is not about tibiofemoral joint many times. It's the extraarticular tissues and the extensor mechanism. And that's the message I want to give here. So, any questions so far? Anything you want to add? I want to make this as interactive as we can. Okay, so I'll pose another question. How much walking should a patient do? What's the standard method of ambulation in your practice? When does patient stop using walker? When does he go to a cane, or do you use a cane at all? What's the standard recommendation?
So here they are following. After the suture removal, they shift from walker to cane.
Everybody, or depending on patient, or
usually the standard program is like this.
But what if the patient has not good balance? How do you test the balance? What if the patient has a positive Romberg's test? What would you do then?
We'll prolong the period of walker.
So that means you have to add a balance and safety test, right?
So
that's all I meant. You have to add a balance and safety test. Do you use rolling walkers or just four-legged walkers?
Rolling walkers.
Rolling. So just to add, you must do a balance and safety assessment before you let the patient go from walker to cane.
Yes,
do you actually practice with the patient cane walking before you let them do it, or just tell them to use the cane in the opposite hand?
We make them walk in front of us.
Good. And
We
check their
check
balance.
for the balance.
Good. Okay. How much walking should I do? I'm 3 weeks out.
So not more than 30 minutes and not more than 2 times a day. If the swelling is under control.
Good. When can I walk unlimited distances?
So with knee full extension, 0 should be achieved. Swelling should not be there and good balance should be there.
But when can I walk unlimited distances?
So it depends upon patient's response to the inflammation, like how
Good.
soon he is developing.
Good. You're talking my language now. So you have to gradually increase their ability to walk. What's the goal?
Patient should be able to walk without developing the swelling. So
and what should be the speed of walking be? The goal, final goal.
So earlier we don't focus on speed, we focus on the pattern of gait, symmetry of gait, stance time, stance length, step length.
You mean step length, okay.
Yeah. And so gradually, once that is symmetrical, we will work on time. So then we will time the gait. Suppose he is taking for 30 meters, he is taking 1 minute. So we will ask him to walk same distance in shorter period.
Okay.
Yeah.
And what, do you make a chart for the patient as to how much walking they should do and how to gradually progress?
So I usually explain them what is their status of swelling, what is their status of control they are feeling, and like it is patient based. So I explain them can gradually progress according to their pace.
So patient is 3 months out.
Hmm.
He has within 5 degrees of full extension, has 115 degrees of range of motion, active, 120 passive.
Okay.
And he's walking at 1 kilometer per hour. Is that good or bad?
No, that's not good. He should be walking with 0 knee extension.
Many times they don't get 0. If you look at the Jackie Perry's original research, many people walk with 5 degrees of knee flexion throughout, even normals.
So what is his normal knee end range extension? That also depends on normal.
It's also
knee.
5 degrees.
Then it is good.
Okay.
Yeah.
Even if it's not there, you have to accept it. It's 3 months out, they're not going to come for therapy. What should be the walking speed?
No, sir. We need 0
I want
degree.
you to go to PubMed and read an article called "How Fast Does the Grim Reaper Walk?" You know what's Grim Reaper, right?
Yeah, sir.
Okay. So how fast does the Grim Reaper walk? It's an article that was done on more than 7,000, I think, older patients. And what the data shows is that if you walk up to 3 kilometers per hour speed for 30 minutes, 3 to 5 times a week, your chance of dying from heart disease is reduced by 95%. So everybody should read. I will share a poster I made on this topic with Sona, and Sona can share with all of you.
Yes, sir.
It's very important.
This is one of your favorite. I think, sir, this is one of your favorite articles.
Yes, walking speed is one of the vital signs now by many people, and I agree. If you can sustain walking with a reasonable step length, cadence, and have a speed of 3 kilometers or more, ideally more, but even 3 kilometers, your chance of dying from stroke or heart disease over a 5-year period in older patients is reduced by 95%. And if we are going to change people's health, we have to remember that the only way we're going to change is in the early phase, get pain-free range of motion, good muscle control. But in the end, you want them to return to the activities that they couldn't do before, so they are more healthy. Otherwise, what did we achieve? We did a total knee and they put on more weight, got more fat, and died of a heart attack in 2 other years. All the money wasted. All of the effort wasted. Thousands of dollars or rupees, whatever it is now wasted. Nobody benefited from it. It did not change medicine. It did not change anything. You made money, I made money, surgeon made money, patient got no benefit because they don't have long-term benefit of it. So walking is, and I know Pune is one of the walking cities in the world. Everybody walks there. The question is, what's the quality of walk, number one, and number two, is the speed adequate to cope up with the heart and the lungs and the circulatory system to do it? That's a question. So everybody that does musculoskeletal rehab should read. There are many articles on this topic, but this one is the most interesting one because it has interesting. Sona, do you have that article? Did I give it to you?
Yes, sir.
Okay, can you share with everybody?
Yes, I will do that.
Okay. So everybody should read that and focus on walking speed. Now, what's so great about walking speed and total knee replacement? So I call this functional range of motion. If you have to walk at 3 kilometers per hour, do you know what the angular velocity of the knee joint has to be to go from? What's the range we need for the walking? Everybody know that? This should be on tip of your tongue. Range of motion of the knee during walking is how much?
Anyone can answer that. I think normal gait cycle everyone knows.
What's the normal range of motion in the knee joint?
0 to
It
60.
is 0 to 5 to 60 to 67 degrees. In older patients, it can be as low as 55 to 60 degrees. In younger patients, it can go up to 70 to 68 to 69 degrees. Does everybody know how much you need to walk a normal step up?
$80.
For a 7.25-inch step, for a 5'6" tall person, you need about 90 degrees, 85 to 90 degrees. Do you know what you need to have the leg, trailing leg, the total knee as a trailing leg and come down the step?
Approximately 100 degrees.
Correct. 100 to 105 degrees. 110 ideally, if you have narrow, especially when the steps become narrower, like in a house versus in an industrial area or in a commercial area, the steps are a little bit wider in depth. So yes, anything above 100 to 105 is ideal. Does everybody know how much for bicycling?
It depends on height of seat.
No, on standard seat. You know what's a standard seat? It's
80 to 120 degrees of knee flexion.
115 to 120 degrees of knee flexion. Right? How much to do a deflection in cross leg sitting? 125 to 135. You can do it at 120, still tough, but 120 to 125, you can do it. 135 is really good or adequate. So you must know this right away. But the more important thing is, what's the angular velocity when you walk and you have to produce 50 degrees of range of motion in few milliseconds? You're going from, remember, you're going from almost extension to loading response knee flexion, which is 15 degrees in few milliseconds. Then you are extending the knee again to within 5, maybe 7 degrees of extension in the mid-stance phase. And then you start flexing again to go to 50 degrees in few milliseconds again. The total gait cycle is in the stance phase is 300 to 600 milliseconds, depending on speed. So everything has to be quick. So the flexibility of the tissue is not just about what you achieve in your hands. I got 100 degrees of range of motion is meaningless if patient is only using 20 degrees. So always look at patients walking and functional range of motion and not just goniometric range of motion is my point here.
Sir, I have a
Yes.
doubt.
Yeah.
So in after total knee replacement, there is a life of every prosthesis.
Yeah.
So so how much should we load the prosthesis? And when should we consider that, okay, we should limit our rehab till this point? Because life of prosthesis is also limited.
I don't have experience of what the prosthetic life is in India because I have not done rehab in India. But the current prostheses here that are used, the life, depending on number of cycles testing, is 30 years. We have now, and I'm in the position where I can tell you I have 20 to 25-year follow-up on many patients, many. And same with the hip as well as knee. And these are active people who are doing skiing, who are doing doubles tennis, even some are doing singles tennis, walking up to 5 miles every week, maybe 10 every week, doing all the activities of daily living a normal life. We have patients who are in 85, 90 range now with 20, 25-year follow-up. And it's always comes down to early rehabilitation, early range of motion, getting the strength back to where they need to be, and what I call tune up, and going to health club 2-3 times a week and walking. That's kept our patients going on for long period of time with long follow-up. So this notion that prosthesis doesn't allow load, that's a cop-out. That's, in my opinion, is BS, in my opinion. It's not about that. To hold patients back from activities that they want to do now, you have to train them. You don't want them to do jumping and running and things that, but closed chain activities are okay. Walking is okay. Playing doubles tennis is okay. Playing golf is okay. Going for skiing is okay because it's closed chain actually. Falling when you're doing the skiing is not okay. So if you want to wear a brace, that's fine. It protects you. But there are lots of activities that we allow our patients to do routinely. And they are very engaged. But that's what change in medicine is, right? It's not about what did you achieve if you are walking with a cane and you walk with a cane again and did not improve your quality of life, then what did we achieve? Nothing. So we have to always look at, not every patient will do everything that I say, but we have to, our job is not just to treat patients, we have to encourage our patients to do better all the time. And unless we are going to do that universally for all our patients, there are only few patients who are really motivated to do well and others won't. So that's the point. I think most prostheses today are well made and can last decades of use, proper use. Proper use is, remember, if you walk with a flex knee, you will wear out your prosthesis in 5 years. If you have a bad alignment, you will wear out in 3 years. If you hyperextend your prosthesis, your posterior control is poor, you will wear out in maybe 2 years. So, of course, walking in what range will matter. But to say a well-functioning total knee, that, oh, this is a prosthetic implant and you should never do certain things, that's a cop-out. That's BS, in my opinion. And that's my belief. So we always do this. This is just to show you what we do in terms of risk stratification. Our therapy is not based for everybody the same. Everybody's therapy is a little bit different based on age, gender, BMI, previous surgeries, important, abnormal inflammatory markers if they have it, tightness, contractions preoperatively, neurological conditions, and if they have diabetes. Uncontrolled diabetes is a bad thing for patients. So we strategize our treatments based on this, and this is some of the things that we ask even after surgery if they do not see them preoperatively, because we don't believe in tablet physical therapy. We don't do it 3 times a week for everybody. We don't do daily therapy for anybody except for post-manipulation, a really challenging patient. We only do it 2 to 3 times a week. And we believe that most patients after total knee should be done with their active rehab in 6 to 8 weeks. So maximum number of times we see patients is 18 to 24 visits at best. So you have to get done by then, but then we follow up our patients in the first year every 3 months, I do. Not every therapist does it in the United States. I do, our center does. And then after a year, once a year, we offer them the visit back. And most people who are really invested in their knees will come back. And sometimes we'll find that needed shoe orthotics. Maybe they need, there are certain weaknesses that they have developed, especially in the hip joint, that affects the knee joint. That's a separate lecture by itself. And I think Sona can talk about this. She's done some research with the students there. Sona, have you talked to the students about your hip research?
So not yet.
Okay, all right.
But
you should tell them about your hip research, your findings. They're very interesting findings. And that's been supported by other patients. So all those things matter. And this topic can go on for a long, long time. What I want to do is really make this more interactive next time. I will offer one more session on total knee, but I want you to come prepared with questions. And I want you to read more about biomechanics, read about gait mechanics. Come more prepared next time. We will give you 2-3 months to really hone down on knee problems. And then we can have more discussion about a scientific discussion, fact-based, on what the literature supports, what doesn't, and where we go from here.
Right, sir.
Okay.
Yes, I think we are kind of, I think it's been an hour exactly since we kind of started. So I guess as usual, time is always a constraint, and we just feel like we want to just keep listening to this beautiful clinical pointers that you give throughout your talk. And I'm sure it changes our perspective about treating a patient for sure. And we also kind of know about how much we can do with just good therapy and how much change we can bring about. So, it's very, very important and critical that we know how much we should and should not. The do's and don'ts, I think, are more based on many assumptions. So I think we have to break that by just looking into the evidence out there and also listening to people with experience talk. So that's going to go a long way in the way that we are going to handle our total knee patients. And today's talk has been just one of those many that I've heard sir talking about, and it's changed the way that I look at a patient and I treat a patient. Even given that I have many years of experience, it still makes that change whenever I hear him talk. So, sir, it's actually been a very incredible talk. I am sure everyone who has attended this agrees with me. And we will kind of meet next time, because I too have a lot of questions which have popped up in my head just as you were talking. So we will have a part 2 of this session very soon. I guess we can just take a couple of months break and then we meet again, regroup, and we kind of, based on whatever queries have developed, especially in early rehab, before we move on to later rehab, at least on early rehab, what are the things that we should concentrate? What are the things that we do in the hospital, and then how do we go about once the patient is discharged? How soon do we push for the range? How soon can we use and deeper soft tissue manipulations, or how soon can we use a tool or a-stim? How soon can we make the patient kind of do the eccentric control? And so there have been a lot of questions which have kind of built up after this talk, but I guess we'll have another session to address it. So I guess from all the students, postgraduate students, as well as me, I think we will be looking forward to the next session. And I'm sure sir will be kind enough to kind of do it as soon as it's feasible for him to. So on that note and on that promise, I thank you for taking out your time. It's been really, really early morning for you, and yet you made up the time and took this special session with us. So we are really very indebted to you, and can't express the gratitude with which the same kind of passion that you take these talks as you have always taken. And I'm sure the students are going to be motivated to now go back, look into evidence, read more, and come back more prepared for the next time onwards.
Okay.
So sir, thanks from the entire Physio TV team here. And I also thank Parag sir, our chairman, as well as Manisha ma'am, Manisha Sanghvi ma'am, our executive director, as well as our principal sir, Dr. Apurva Shimpi, for always being the model and the emotional and all support to us for Physio TV activities. I thank Dr. Tushar for his IT support. And of course, last but not the least, I think, and above all, I thank Bhave sir for taking out the time for this.
Okay.
I also thank all the students who have attended, and thanks for asking pertinent questions and trying to answer the queries put up by sir.
Okay.
Thank you so much.
Thank you again. Bye-bye.
Bye, sir.
Thank you so much, sir.
Have a good day, sir.
Okay, bye-bye.
Bye.